So this was the instructions that I had from Roger. Give us the 10 tips that seem essential to you to respect in order to minimise the risk of revision when you're setting up a knee replacement. So the key here to my advice is an evidence base for what we should do to minimise the risk of revision. So this is not necessarily talking about getting better results, although that should correlate to your risk of revision. So for me, I'm going to give you the top 10 reasons for revision and my tips to try and avoid them. So if we look at the registry, I talked about the registry earlier today. On your left there are the lists of causes of revision from the registry. There are 14. And I've converted them into a list of 10, top 10. So I'm going to talk about those issues and ways in which we can try and avoid those. So this has been mentioned before, and this is one of the biggest things that I face, I think, is not people who've had specific complications, people got unexplained pain and satisfaction. And as people have mentioned before, this is up to 20% in some studies. And in Australia, we do 50,000 a year. That's 9,000 unhappy patients. If I do 300 knee replacements in a year, that's 60 patients, which makes your life very miserable. So there's a lot to be said for reducing this number. I'll just give you some of our own personal experience. We did a study where we called 375 patients. We had 301 who responded. And we asked them, are you happy with your knee? Are you very happy, happy, neutral, dissatisfied, or very dissatisfied? And when we grouped together the group that was very dissatisfied, dissatisfied, or neutral, so anything but happy or very happy, that was 8% of our patients. I don't have time to go into all the methodology here, but I can tell you the conclusions from this study was that our dissatisfaction rate was 8%, so not too bad. Pain and stiffness were the main reasons. And people who are dissatisfied tend to be people who had better knees to start with. So better range of motion, their x-rays weren't so bad, and this has been touched on before. And they had similar scores to the arthritic patients, the happy patients, but they didn't get the same improvement. And we did a lot of psychological testing and found that these patients had a higher tendency towards depression, pain catastrophization, and what we call a low internal locus of control. So they were patients who felt that everything was up to somebody else to fix their problem. And these are psychological tests that you can do. So in order to try and help predict these, we've developed a model from the Osteoarthritis Initiative, which is a big, big database of knee arthritis patients in the US, and it collects a lot of information about these patients, and then with the subset that's had knee replacements, it can correlate that to their outcomes, with post-operative pain score being the target. So we can use this like a big data set to try and predict outcomes. And so we've converted this into an algorithm that we're just testing, so patients will answer questions on an app. It gets fed back to the server, and using those predictions, it will tell us what they think the outcome of their knee replacement will be. So this patient here is starting in the red zone, the bad zone. We click where they're going to be afterwards, and that looks like they're going to get a good improvement. So this is something that we're continuing to validate. So in order to reduce this unexplained pain and dissatisfaction, don't offer knee replacements to patients unless they've got really bad arthritis, they have a lot of disability, they've tried all the non-surgical treatment, and they have appropriate expectations. Consider preoperative screening, possibly by these sort of algorithms, and consider counselling preoperatively for patients who you think may need a knee replacement but have psychological issues. Number 2, prevention of primary infection. So there are a number of things here that are important. Optimising the patient preoperatively is very important, and there's a number of things here that we've started to do more recently. Avoid surgical site contamination. That's the #1 cause of primary infection. Consider intraosseous antibiotics for the higher-risk patients. We use the dilute betadine wash, which I've just been using over the last 12 months, and I was actually surprised to find out there is some evidence for using this. And we use reducing wound complications, so minimal anticoagulation and very careful wound closure. So there's a lot of evidence that surgical site contamination comes from everything around you. So there's a lot to be said for controlling that. This is my operating room when I'm doing a joint replacement. Nobody's allowed to come in unless they're part of the team. And there are other devices that are becoming more popular, UV devices to sterilise the atmosphere and the surfaces, filtration devices to control the air, and these are things that are becoming more and more popular. So I think infection is going to be one of our biggest things that we face in the future. Intraosseous antibiotics, I'm not sure if that's been done here, but it certainly is something that we tend to use for revision in higher risk cases. And one of my friends from New Zealand, Simon Young, has done an entire PhD on this, showing in a number of studies that you get much better concentration in the tissues and much better efficacy with this method of intraosseous vancomycin, or cefazoline's been used as well. Preventing secondary infection, this is my biggest cause of infection. I do a lot of knee replacements, so I get patients 1 or 2 every year who come back with a secondary infection. So obviously the patients need to be educated about this risk and things like good oral hygiene, good skin hygiene. But as I mentioned this morning, use of highly cross-linked polyethylene particularly using a CR knee rather than a PS knee, on our registry has a much lower rate of infection going forward into the future. And this has been published, as I mentioned today. So in order to reduce infection, optimise your patients preoperatively, minimise that risk of surgical site contamination, consider using intraosseous antibiotics for the high-risk patients, reduce the hemarthrosis, which I'll talk about later, and use highly cross-linked polyethylene, preferably a CR implant. Avoiding stiffness, number 4. So minimise the soft tissue trauma. I, like Jan Victor, used this minimally invasive approach. I went through it as a bit of a fad, and I don't do this anymore, but there were some good principles from there. And there's certainly a good idea not to just do any more dissection than you have to. Manage the soft tissues carefully. Careful balancing and very precise rotational alignment. So I still use the spacer blocks, but I also use some of the newer devices like the VeriSense that people have had some experience with here. And this helps me to fine and control my balancing. I think reducing a hemarthrosis is critical. And pain management. Pain management is one of the biggest advances we've had in knee replacement over the last 10 years. Keeping patients on top of their pain so they can do their rehab in a very controlled way. Patients don't need to be pushed hard, they don't need to be punished. As long as you control their pain and their swelling, everything should be pretty easy post-operatively. So this is the VeriSense, and I've started to use this over the last 2 years. For me, I don't think it adds a lot. I think it is actually useful in some of the harder cases that are more difficult to balance, and it can help us in things like selecting the right polyethylene size, but it hasn't been a major advance for me, but it's certainly a tool that we can learn from during the procedure. So number 5, avoiding malalignment. Embrace technology. Okay. Now I think there are some very good surgeons in this room who use some of the older-fashioned techniques, and I guess when I see people presenting their work, the biggest thing that comes through is that if someone does a good job at what they do and they're experienced and they take care, they're more likely to get a good result. But we've certainly seen from our registry that computer navigation correlates to improved survival in the younger, more active patients. I'm sure this is because they get a more precise result. So either do that with a better technology or do it very carefully, as previous speakers have mentioned. Avoiding instability. So ligament balancing is obviously critical. Restoring the joint line has been mentioned before. I think it's very critical. Choosing the right implant. And we're doing some research now on individualized alignment. So you all have heard about kinematic alignment and adjusted kinematic alignment and mechanical alignment. So we're doing some research where we analyze patients' anatomy. We do simulations of the implant in their anatomy, and that then produces a prediction for us. And this is something that we're just starting to look at now. So, for example, this patient, green is good. And on the bottom left hand, where it says 0, 0 in each diagram, that's pure mechanical alignment. As we go further up that y-axis, we're getting more towards what would be considered kinematic alignment. So as we get to red, that's worse. So this patient, whether they have CR or PS, would be predicted by the simulation to get a better result in mechanical alignment. This one is the opposite. So this is something that we're looking, where we don't just have one size fits all for every person. We're trying to look at individualizing their alignment. And that, I think, helps sort of balance the knee and get a better result, better functional result. Avoiding prosthetic wear and loosening. So pick an implant that you know has a low revision rate and use a highly cross-linked polyethylene. This is what happens when you use highly cross-linked polyethylene. You get a much lower revision rate. And then this is a study that one of my friends in the Gold Coast in Australia did. And he looked at all of the things that you can choose when you're choosing an implant. And he picked the ones that had the lowest revision for each of these factors. And he found that if he created a virtual implant with all those factors, this was the difference in the revision rate. So 2.8% compared to 6.7% over 13 years. So the optimal prosthesis from that study, from our registry, was a minimally stabilized fixed bearing with cross-linked poly and resurfacing the patella. Avoiding extensor mechanism complications. So obviously very careful exposure, that's been mentioned before, particularly in stiff knees and knees with a low patella baja. Rotational alignment and soft tissue balancing is particularly important, and this is something that I think image-based navigation or PSI can help with our rotational alignment, because it's something that is quite hard to visualize when you're doing the surgery, particularly on the tibia. I think the femur is a lot easier, but we've been using PSI to help our rotational alignment, particularly on the tibial side, and also to assist with it on the femoral side. A careful resurfacing technique. An argument against resurfacing is complications of resurfacing. Personally, I think they should be extremely rare, and even with the thin patella, we should be able to resurface the patella without getting a fracture. Avoiding hemarthrosis and wound complications. I don't use a tourniquet, I don't use a drain, haven't done so for many, many years, and there's very good evidence for that. Tranexamic acid has been a game changer. It's been a huge advance, and it really, as this previous speaker has mentioned, does reduce our rate of hemarthrosis and stiffness. I think a careful closure, I use these knotless sutures, the barbed sutures, it gives me a good closure. I do a very careful closure myself. We use this mesh and we use glue to make sure we minimise the wound ooze and get a much better result for the patient and reduce the risk of infection. I use minimal anticoagulation, so I just use aspirin for the majority of patients. That also reduces the wound ooze and the hemarthrosis. And the final one is avoiding the secondary patellar resurfacing. So once again, there are meta-analyses that say this improves the results. There are meta-analyses that says it doesn't. But if you want to reduce your revision rate, you resurface the patella, and particularly if you're using PS or medial pivot implants. So in summary, choose your patient carefully. Choose your implant wisely. Consider your preoperative planning and be very careful in what you choose to do for the patient. Fastidious asepsis is very important. Careful soft tissue handling. Precise surgery. Either embrace new technology or be very careful with the technology you're using, understand it and use it well. Control the bleeding and make the wound look absolutely beautiful. Manage pain and swelling. Control steady rehabilitation. And then appropriate expectations for the patient. Preoperative counselling and look after the patient. And if you do all of this, then you may get a patient like that, which is the ones we see in all the brochures on orthopaedic surgeons' websites from the implant companies. Thank you very much.